We're good.
Okay, hello, Caitlin. Thank you so much for joining our organization for our interview process. It is a pleasure getting to know you. So, can you tell me about yourself and what led you to become a family nurse practitioner?
Hi, so my nursing career started, I started at a level one trauma center on the neurotrauma step down unit. So that ratio was about a 3 to 4, pretty high acuity patient ratio. So while I worked there, I really learned good critical thinking skills, especially under pressure. I also got to act as a charge nurse and a mentor as a preceptor. During this time, I also started working as an aesthetic injector at a medical spa and got to dip my toes into the outpatient world a little bit. This expanded my confidence in being one on one with a patient and really assessing, recommending, and educating, as well as building rapport with patients because you were building more long term relationships with them. So, this is when I decided that I liked the outpatient world and that I really wanted to be able to treat patients across their lifespan with a more broader and preventative type of care approach than the high acuity, high intensity approach that you see in the hospital.
Okay, and what made you choose family practice versus any other specialty area?
I liked family because it has a variety of complexity and ages, and you really get to see patients across all stages of life, from babies all the way up to geriatrics. Also, working on the neuro unit, I saw firsthand how chronic conditions can spiral when they're left untreated from a lack of primary care, as well as how devastating effects of complications such as a stroke can be from risk factors and diseases that were not being taken care of with preventative medicine because either a lack of access to care or mistrust in a primary care provider and just avoiding to go to see one. Um, Also, in aesthetics, I do see patients regularly, and I really liked that continuity of care and being able to follow them throughout multiple years rather than just seeing them inpatient for a few weeks and then never knowing how they are after that.
Oh, that makes great sense. Thank you for your robust response. So, what do you think are the most important qualities of an effective F&P?
I think the most important qualities are, of course, strong clinical thinking skills and a strong clinical background knowledge, but most importantly is good communication skills. Patients need to trust that you're hearing them and that you're listening to their concerns and that you're not just brushing them off, as well as trust you and feel trust that they can feel comfortable with you to tell you their issues and want to come see you, not just procrastinate or be afraid to go to the doctors, and that they're not being judged when they are telling you these issues. I think critical thinking and clinical thinking is important, but it's only one part of the picture, and that empathy, as well as knowing when to refer and collaborative decision making, is just as important as well.
Yes, and speaking of collaborative decision making, can you describe an example of how you have worked effectively in a multidisciplinary team?
So often on the neuro unit I work at, I have to act as the charge nurse, where your role is really to coordinate and control communication between all of the interdisciplinary teams. So that includes providers, the other nurses, the nurses' aides, management, nursing supervisors, staffing, beds, case management, social work, PT, OT. We often meet in the morning in interdisciplinary rounds where, as the charge nurse, you sit at the table with all of these different members and go through patient by patient and discuss concerns, and you kind of advocate on the nursing end of things. Most recently, we had a patient that has been in the hospital for 3 years on a 2-to-1, so two PCAs per one patient. And she has had multiple suicide attempts, even with these two PCAs in, is constantly pulling out her trach. So they need to rotate her throughout the hospital every month or two so she doesn't form too close of relationships with the staff and
Mm.
manipulation starts to occur, and then more and more code airways start to occur when she builds a rapport with the staff. So that required me to meet with respiratory about what to do if she does pull the trach, meet with the old manager of the unit she was on previously, meet with the nursing supervisor, meet with our manager, speak at a huddle with all of the nurses to educate them on what to do, meet with all of the aides, create a binder of her whole care plan. So that was really a interdisciplinary approach to keep her safe.
And which populations or conditions do you feel you're most prepared to manage?
So my background knowledge definitely is strongest in neuro and musculoskeletal, as that's the population I work in. Also, I do typically take care of more of a geriatric age range, not so much PD, and a
Mm.
lot of chronic conditions. So one thing that gives me a strength in is that for strokes especially, they don't just occur. Often there's multiple risk factors or comorbidities that lead to the stroke. So I do get to see a large background of common medications that are used to manage these conditions outpatient or medications they start patients on to manage them once they're discharged from the hospital. Um, in aesthetics, I've built a good and learned to build a good rapport with more of the female middle-aged population as well. So I'd say my strengths are definitely in that, and my weaknesses are definitely more of the pediatric population.
Gotcha. Well, thank you so much for being vulnerable about the population you're most comfortable working with. So, can you describe a situation where you identified a potential problem in a patient before it became critical, and what did you do to intervene?
So on the neuro unit, this happens a lot. Neuro checks are very sensitive and they're often not black and white where patients wax and wane, and it's often just a subtle change that is the first sign of decompensation, not necessarily a drop in vitals or a drastic change. One situation, I had a patient day shift one day and then 3 to 11 2 days later, and hospital acquired delirium also plays a factor in patients' neurostatus that a lot of times it's difficult to decipher if it's delirium versus if it's a change in neuro. So the nurse had told me she was just kind of sundowning a little bit, was a little confused. And when I took her through conversation, I could just tell that she was a lot more off than when I had her days before and was also having some strange behaviors that she wasn't doing before, such as taking her hard collar off, constantly setting off the bed alarm, incontinence, things like that. So I had advocated for a repeat CT of the head from the provider, and she did have a very enlarged bleed, and they ended up emergently taking her to the ICU and to the OR. So that was just a situation where sometimes trusting your clinical judgment, even if it's not a set vital sign change or a set neuro change.
Wow, that's pretty impressive, even considering the neural assessment is different from nurse to nurse. So even
Hmm.
recollecting your previous assessment and comparing it to the current, like, hey, something's off, and advocating to the provider to intervene with additional interventions is very impressive. So
Thank you.
sounds great. So can you describe a time when you had to educate a patient with low literacy, and how did you ensure they understood the plan of care?
Yeah, so I work in Worcester, Mass, so it's definitely we see a lot of patients that have lower health literacy as well as a variety of different populations and ethnicities. So this situation was a post-stroke patient with low health literacy that was non-English speaking. So first off, I made sure that I highlighted the key parts of the discharge, including on the medication chart with checklists of what times a day they should be taking their medications and tried to simplify it as much as possible.
Mhm.
I also made sure that the discharge was one copy in English for me to be able to understand and communicate with them, and one copy in their preferred language. This patient was a little bit older and lived in a household with multiple other family members, so I made sure that two of the family members that were a little bit younger and had a little bit of a better health literacy were present during the discharge teaching, um, and also included the hospital's in-person interpreter for it. And then I also printed out some additional education that was more picture related rather than a long list of literature for them to read, and made sure that they taught it back to me, that made sure they didn't have any questions. Also utilized meds to beds in the hospital that we have, where the pharmacy will fill their prescriptions before they leave the hospital to ensure that they had all of the medication in front of them and I could kind of show them and make sure that they really understood when to take those medications.
Wow, that is an excellent, robust response to that question, considering you had the two different languages for the instructions. You involved the in-person interpreter and the family to come in, just as you know, because you know when the patients are being discharged, there's so many things they're going
Yeah.
through learning. So that was a great idea. And even having, your pharmacist come and deliver the medications, that was genius because a lot of readmissions are due to patients not picking up their
Hmm.
medications, as we know. So how do you prioritize your day when managing multiple patients with varying needs, considering how much time you spend even with your discharge instructions?
So the first thing always that we start off with that our manager is really strict with is a bedside shift report and making sure that with the nurse you're going to the bedside and seeing all of the patients before they leave. And when you do this, it gives you kind of a good idea of what's going on in the moment in those rooms and if there's any immediate safety concerns that need to be addressed, like someone climbing out of bed, an error with a medication that's being hung, things like that. So after I kind of evaluate that, then I would go and look at my patient's acuity. On the neuro floor, we are a Joint Commission accredited, so it's pretty strict that the neuros and the vitals need to be exactly 4 hours apart or less than 4 hours apart. So something I would look at is when they were last taken and make sure that I'm prioritizing getting those neuro checks in on time for those patients. And obviously, seeing any patients that seemed like they were decompensating the night before or that had a high blood pressure, the last blood pressure check, things like that. And then after that, I try to look at the daily tasks and we give report to our PCAs so we can kind of make sure that we're working together and not against each other. Like coming up with a time that we can both go in there and wash them up and get at them out of bed together rather than them getting the patient out of bed for me just to have to bladder scan and straight cat them a few minutes later. So really just working together on that and kind of deciding what tasks I can delegate to them versus what tasks we need to do together, and just planning out the day.
Wow, yes, that's also very impressive as well, delegating because you have multiple patients as well. And then also, prioritizing patient safety and regulatory requirements. So that's very impressive and very important. And we like to hear that at our facility because regulatory does pay. You got to make sure you get paid for all the great work you're doing. I just can see that you're going to. So, what are your greatest strengths as a provider, and what areas are you working on improving?
I think my greatest strengths are my critical thinking skills and building a rapport with the patients. I also do really like being hands-on with the patients and being present. I think the areas I struggle with the most are still, it's improved over the years, but delegation and trying to do too much myself, or if I have a few free moments, just being like, it's okay, I can do it, I have a minute, which then later throughout the day can end up catching up to you with prioritizing things such as charting. It's easier to be present in the patient's room than it is to be behind a computer sometimes, but the charting and the documentation is equally as important. So sometimes it's hard to remember that part.
Absolutely. And we know Nursing Foundation, if it wasn't documented, it
Yeah.
wasn't done. Absolutely. Can you describe a situation where you made a clinical decision that was later questioned, and how did you respond?
Yeah, so we do IVIG on our floor a lot. And there's certain protocols about when to stop the infusion. There's also its provider preference if they want prehydration, if they don't. So this particular provider didn't want prehydration for the patient. We started the infusion. The patient didn't necessarily have any changes in vital signs or a general assessment, but they kept stating that they felt very anxious, that they felt very jittery, like that they felt unwell. Were really spiraling at the start once the infusion had started. So I had held the infusion and reached out to the provider, asking them to come to the bedside and explained it. And they told me to continue the infusion, that it was none of the symptoms that we should be stopping it for. And I kind of pushed back a little bit and said, can you please come to the bedside and evaluate the patient? The patient also did not want the infusion to be continued until she spoke to a provider. So just really advocated on that behalf. And then once the provider did come to the bedside and evaluated and saw that the patient was sweating, that they were very anxious, chills, they did agree that we should maybe stop, take a step back, do a little bit of prehydration first, and then try to run the infusion at a lower rate than what we were running it at before. And the patient did tolerate it much better after that. So that was just a situation where sometimes balance between following protocols to a T and also using your own clinical judgment.
Yes, which is very important with the independence in this role as a FNP. So kudos for using your clinical judgment to have a favorable outcome for that patient. So why are you interested in this organization?
So, through my clinicals and shadowing, I really love how it's a mixture between MDs, NPs, and PAs, and also how it's a teamwork and collaborative approach. I really love how it's not everyone having individualized offices, that the offices are kind of a joined area with multiple providers, so that as you're charting or as you're reviewing for your next patient, it's kind of an open question policy where everyone is just asking questions and bouncing off each other, which I think is really important, especially as a new NP, because it's impossible to know absolutely everything. And I like that I felt very comfortable, even as a student, openly asking questions and advice from anyone with some people with multiple years of experience compared to me, compared to other NPs, and them sharing their new experience with me. I just think that it's a great practice to transition into.
Absolutely, because you're never going to be alone at this environment as well. So you always can, piggyback and have an extra set of eyes when you're ever in doubt, or just want to ensure that you're giving the right care. So where do you see yourself in 3 years as a FNP?
In 3 years, I hope to be more confident in my own practice and not need to rely so much on asking for help all the time, have a little bit more confidence in my clinical judgment. Um, I'm confident in educating and with a provider above me, but I would like to be comfortable and confident in being the provider role. Also, I'd hope to still have my foot in the aesthetics industry a little bit. Although I'd like to mainly practice primary care, I think having a foot in that industry and being able to combine some of the wellness and more holistic um, practices that are there, such as like hormone testing, the weight loss therapy, the conferences I get to go to, and continued education I get to receive at that, kind of integrate it a little bit into my regular primary care approach to treatment.
So what electronic medical record systems have you used?
So
And how
I,
comfortable are you with charting and documenting?
sorry. So I've used Epic primarily in the hospital, which is a great charting system. It's very universal, very user friendly. I've
Mhm.
also used Simplast and Boulevard at the medical aesthetic. But all of them, I've learned to do head to toe assessments with Epic in Simplast and Boulevard. I've learned more of the outpatient approach where you're the one putting in their allergies, their health history, their medications, doing the patient intake, where inpatient through Epic, I'm not necessarily the one that does that whole intake with them. So both sides of the spectrum. Also, both jobs require thorough notes, especially in the aesthetic industry, because you are writing an order for a nurse practitioner to review and sign. So you have to be very detailed through it. So yeah, mostly Epic and then Simplast.
Okay, well that's perfect because we do work with Epic, so at least you're somewhat of a connoisseur with that. I would say. So there shouldn't be any learning gaps. Just, probably just our template, our flow sheet template would be new for you. So do you have any questions for me?
Yes, so what continuing education or transition into practice period do you have at the organization to help new graduate nurse practitioners feel comfortable with that entry?
Well, our organization offers a robust support system for newly graduated FNPs through structured onboarding systems and programs as other traditional places do. This includes assigned preceptors during the first few months, as well as consistent consultations with clinical mentors or leads providers. Furthermore, the new FNPs have access to support from our interdisciplinary teams, continuing education opportunities, case review sessions, and they're all aimed at enhancing their clinical confidence and skills. So we do hope that you feel supported, but you can also come to me or your direct supervisor at any time if you have any additional needs, concerns. If you want to branch out and learn something or you're struggling in something, we can provide you reference materials based on evidence-based practice at any time.
Awesome. Okay, thank you so much.
You're welcome, Caitlin, and we look forward to contacting you regarding next steps about this interviewing process.
Okay, all right. let's switch. I'm trying. Uh-oh, are you frozen? No, okay.
Am I no?
Okay. I want to make sure we have enough time. Okay.
I think we do.
We do. Okay.
Yeah, my questions aren't as elaborate as yours because I really don't have that much PMHNP experience.
Okay. I
So
also just talk a lot when I'm nervous, so.
I was like, her answers are so good. How am I going to answer like
Yeah.
questions like that?
Okay. Hi, Angela. It's nice to meet you. Thank you so much for interviewing and being here today. First, I want you to just tell me about yourself and what led you to pursue the primary mental health nurse practitioner pathway specifically.
Well, I've been a registered nurse since 2004, so my foundational experience is on acute med surg, and my journey into psych mental health nursing stems from a deeply personal place. So, transitioning to life as a young widow and single mother from 2019, that grief experience ignited passion for mental health, particularly in helping others who were navigating loss as well. I chose the psychiatric mental health nurse practitioner pathway because it allows me to provide long-term holistic care while creating a safe and supportive environment for those in crisis, especially underserved populations like young widows, because it is tough grieving yourself and also have to support your kids as they're grieving and take on additional responsibilities that your absent spouse is no longer available to.
Well, thank you so much for sharing your personal experience. I think that's so important that patients are going to be able to connect and that you're in this for the right reasons. What past experiences, clinical, academic, or personal, have helped you prepared for this role?
Well, my clinical experience began on a fast-paced night shift med surg unit, so you already know that there was a lot of psych things that I was navigating during that time. But that's where I built my strong foundation in patient care. Later, as an RN coordinator and improvement advisor in the quality department and management area, I developed leadership and system level thinking. Personally, surviving the loss of my spouse, becoming a single parent helped me grow in empathy and emotional resilience as well. So I feel that these experiences have prepared me to the approach of psychiatric care with both compassion and structure. In addition, I did attend a couple of group therapy sessions for widows as well. So I got to see the different dynamics between the facilitator, the actual members, and how they were all interacting in different aspects of life because they were all in different, some had children, some had to move out of their house. There were different situations going on. So I kind of helped navigate that group therapy as well.
Yeah. Um, how about can you describe a time when you helped someone in a mental health crisis? What did you do and what was the outcome?
Well, while I can't disclose specific patient cases due to privacy, I can share that in my current role in quality management, I've learned and worked with staff experiencing burnout and emotional stress during the COVID-19 pandemic. We were all, as nurses, if we weren't working on the units, we were pulled into other areas. And so, I mean, just working with the patients, I even worked on the COVID-19 unit when they first started developing the medications. So I was the charge nurse for that, and I worked under a lot of travelers were under me. So navigating that experience from, supporting the actual travelers, being in the management area, and also supporting the patients was critical, and that kind of helped me as far as a mental crisis is concerned. I also supported colleagues through the panic and grief by helping them access EAP services, debrief emotionally, and refrain from their situation. So that reminded me of how clinical emotional validation and resource navigation are in moments of crisis.
Yes, the COVID was definitely a time that everyone struggled, especially in the hospital. Um, what qualities do you believe make someone successful as a primary mental health nurse practitioner? And which of those are your strengths? It sounds like you already have a lot of strengths, but
Yes, well, thank you so much for acknowledging my strengths. I do believe that a successful psychiatric mental health nurse practitioner needs to be emotionally intelligent, empathetic, resilient, and grounded in clinical knowledge. My strengths include a deep passion for understanding the disease processes, especially how they relate to mental illness, and a sincere drive to build long-standing, trusting relationships with my patients, as I do plan on seeing them, beyond their initial assessment. And I also bring leadership skills and commitment to emotional and continual learning, which I believe are crucial in this evolving field.
Yes, I agree. How do you handle conflict within a healthcare team or with a patient?
Well, I approach conflict with the open communication and a goal to understand before being understood. So, my background in quality management has trained me to navigate difficult conversations with professionalism and empathy, even in leadership and regional settings. I believe in creating collaborative spaces where everyone feels heard and respected. And whether it's a patient being frustrated with care or a colleague with differing opinions, we navigate those together and try to, do conflict resolution in a professional manner.
Yes. So I know you said you worked crazy night shift. Give an example of a situation where you had to set priorities quickly in a high pressure environment.
Well, working nights on med surge, required rapid prioritizations daily, right? So one shift I had a post-op patient who was developing signs of sepsis, while simultaneously, a fall risk patient who attempted to leave their bed. And so I called for help, initiated the sepsis protocol per regulatory requirements, and coordinated team responses to ensure both the patients received appropriate care quickly and also that the environment honed my ability to stay calm under pressure and to triage the cases effectively and transfer patients amongst, you know, going for diagnostic testing or whether they were going to another unit effectively and efficiently.
Awesome. What kind of mental health setting practice setting are you most comfortable working in and why?
Well, I envision myself thriving in an outpatient telepsychiatry setting, hence the reason I applied. Ideally, in a private practice, it would allow me to form consistent therapeutic relationships and tailor care to individual needs. My career goals include creating a practice model that serves underserved communities like minorities and young widows while offering flexibility and evidence-based care. I can also work outside of those realms, but that would be my preference.
Yes. Um, what do you want to learn or improve during your first year as a primary mental health nurse practitioner?
Well, I want to enhance my pharmacologic decision-making skills and gain more confidence in managing complex psychiatric situations and conditions. I also aim to improve knowledge retention because historically I had struggled during, high stake exams. So my goal is to translate clinical knowledge into impactful care while continuing to refine my critical thinking and prioritizing under supervision and
Thank
eventually
you.
branching out on my own.
Thank you for being vulnerable and sharing some of those weaknesses. I think everyone feels that way when they first start. What is one thing you want employers to know about you that might not come through on your resume?
My resilience. So, having lived through personal trauma and coming out on the other side, I bring a deep level of empathy and understanding to my practice. I'm committed not just to professional growth, but to meaningful human-centered care. I also bring a unique blend of frontline experience and quality improvement expertise that allows me to think systematically and compassionately.
Wow, that's great. Um, if I were a patient or a colleague, what would I say I appreciated most about working with you or underneath you?
You likely say that I make people feel seen, heard, and valued. Patients would say I bring calm to chaos and offer hope even during dark times. Colleagues would probably describe me as dependable, collaborative, and someone who brings thoughtful insight to every situation. And my presence is one of support and not judgment.
Awesome. Thank you so much. You have a ton of qualities, and your story is amazing, that we're looking for. Thank you for interviewing with us and putting yourself out there. Is there any questions that you have for us?
Yes, yes, and thank you so much for acknowledging all those qualities and the how smoothly our interview went. So, a question I have for you would be, what qualities, skills, or experiences do you have? Do you believe are most important for a new psychiatric mental health nurse practitioner to succeed in this role and thrive within your team?
Yeah, so I think that experience is one thing, and I know you were nervous that you have more of a medical surge background rather than a psychiatric background, but I think knowing pharmacology is only one part of the picture, and having a calm presence, being present with your patients, showing empathy, compassion, All qualities that you seem like you do possess is equally as important. There's always going to be people here to help you when you first start with the pharmacology aspect of it. Um, but you can't really teach compassion or empathy or that set of skills.
Wow, thank you for that feedback. I do feel very confident knowing that I do have that support and I can be vulnerable with my colleagues regarding pharmacologic care because I know that that is very important, a very important aspect of our management and treatment for these patients. Well, thank you so much. I look forward to getting and receiving a phone call or email regarding next steps.
Yes, thank you.
You're welcome.
Let me